Okay, welcome everyone. We'll wait 1 minute to start. We are meeting all the participants. Happy to have you all. Good morning or good afternoon or good evening, depending where you are in the world located at this time. We will have today our second session of this virtual education series on complex upper extremity trauma. This is an initiative led by Harvard Global Orthopedics Collaborative and SONA Global. We are very pleased to have you all here today with us. So in order to stay on time, we will start. The course agenda, here's a brief summary. Last week we had a great session on radial head fractures. Today we will be talking about and discussing about some humeral shaft non-unions. On December the 2nd, we will go through one of the best joints in the body, the elbow, to talk about elbow instability. And then on December the 9th, we will be talking about chronic elbow dislocation. You can see the QR code here. And if you haven't signed up yet, feel free to do it. You will more than welcome to join us for the upcoming meetings. It's very important for you to know that there's captions. Captions should be able to be should be working for all of you. You can set them in your own language. I think we have support mainly for Spanish, French, and English, but there might be other. There might work for other languages as well. So you can set that in your own meeting, okay, in your own Zoom. Make sure you click on the show captions in order to see them. We activate them from all of you, so I guess you have access to them right away. You can either raise your hand or send your questions or through the Q&A button that we have. You can comment using the chat or the Q&A, as I already mentioned. And the course objectives of this series of webinars is, number one, to improve all the participants' knowledge on complex upper extremity trauma management principles. Today we'll be explicitly talking about humeral shaft non-unions. We will obviously foster international discussion. We have presented from different continents, and we are very happy to bring different healthcare realities and healthcare systems with their limitations and their resources, and try to learn from what's the best treatment considering those scenarios in order to provide the best trauma care delivery to our patients. And number three, we'll also like to motivate and support younger generations of orthopedic surgeons who are practices in low to middle income countries, and to connect them as well. The course moderators are Dr. Kiran Agarwal-Hardy. He's at this moment on a flight, so he might not be able to join us today. He is one of the leaders of the Harvard Global Orthopedics Collaborative. He works in the Beth Israel Deaconess Medical Center at Harvard Medical School, and myself, who I'm Carlos Prada. I'm a hand and upper extremity surgeon from Chile. I just finished my training in the Rod McFarlane Institute in London, Ontario, Canada. Here we have who make this series of webinars possible. I want to say a big thanks to all of you who have been helping us organizing this series of webinars. You do a fantastic job. This is the team of SONA Global and Harvard Global Orthopedics Collaborative. So thank you for all you do in order to allow us to have these amazing sessions. And I also would like to introduce today our faculties and our case presenters. We have initially two cases to present. One will be presented by Dr. Sarthak, Nepal. He is an orthopedic surgeon working at Nepal Orthopedic Hospital in Kathmandu, Nepal. And we have Dr. Pierre Woolley, the University Hospital La Paz at Port-au-Prince, IT. They will be showing us very interesting cases of humeral shaft non-unions, and we will be going deeper on those cases on our discussions. Then the faculties are Dr. Pierre Woolley and Dr. Edward Rodriguez from Beth Israel Deaconess Medical Center, Harvard Medical School, Dr. Daniele Tuto, he's an orthopedic surgeon working at Samburu County Referral Hospital in Maralal, Kenya, who is also here today with us, and myself. The agenda, as I mentioned, is a brief introduction, the case presentation by Dr. Woolley, then we will discuss about that case, and then we have the second case by Dr. Sarthak, Nepal, and this discussion of that case, and then at the end some closing thoughts, where we will try to review the most important concept of today's session. So, without further ado, I would like to leave Dr. Woolley to show us his clinical case. So I will stop sharing my screen. Pierre-Marie, please feel free to share your screen now.
All right. Good morning, everybody. Thank you very much for having me for this presentation. This case is actually one of the fourth case that I showed in the pre-video that was sent to all the participants. Just a follow-up on it, and I think that it can simulate lots of discussions on stability and outcomes of really big segmental bone defects on the humerus. So this patient was a 22-year-old female. She had actually got a gunshot wound a year prior to coming to our institution. Actually saw her in that previous institution, and she was already 3 years out from injury when that happened. And she basically initially had an infected non-union. The 2/3 of the humerus was completely gone, large segmental bone defect, and in our setting where limited implants and limited options are not possible, we did the initial treatment, debridement, beads, washed it out. She actually went out to follow up for about 6 months until she came back. So a lot of time between what I initially finished doing and what we started. And so what we did was a secondary bone transport using an external fixator on the humerus to complete that gap. And so I guess so I'll just show the case and we can have discussion after. Is that how we do it? Yeah.
Yeah, I think that's the best way.
Yeah. So we did the bone transport progressively up to a point where she again was lost to follow up. We were doing quite well. Hopefully we would be able to gap that out. And then because of her limited settings and the financial issues that we face in low income settings, she went out and then she came back a couple of months after with a pretty good result for at least 2/3 of the bone transport. There was still a gap going on. So we ended up finishing the case with a iliac crest bone graft. We didn't want to redo a transport on that case. And so we did a really peak, trimmed the iliac crest bone graft, put it in. Again, with limited options and limited implants, we did not have more than one long DCP plate, so we had to be creative with it. And 2 months follow-up of that case, we're still a bit worried about, gapping because of the compression issues, but she ended up healed quite well, and actually have a video of her. Hopefully that works. There we go. Not 100% good so far, but compared to what she had, it was a pretty good outcome, and she's actually still doing surgery. She's physical therapy right now. So that's kind of the follow-up of the case that I showed. And I think that can stimulate lots of conversation and discussion on how to treat really large segmental bone defects on the humerus, especially after gunshot wound injuries. So, thank you. That's what I got.
Thank you, Pierre-Marie. So I will start the discussion a little bit this is a very interesting case, very challenging, and obviously something that we are not faced every day with this huge gunshot wounds, and this amount of bone defect are thankfully not an everyday injury. So I will try to come back with the basics before we jump into the specifics of your case. So when you have like a gunshot wound and this concept like an open fracture, what's your first how much time you normally see these cases at your hospital? How do you treat them initially, and what was your kind of objectives and goals when you approach it first?
Yeah, I think the first thing that was amazing about this case is that she was vascular and neurologically intact. That was a big plus for her, but most of these cases are not. And so initially you do your basic principle of the bright man, you wash it out. In this particular case, spacer was put with a big K-wire and some cement that we did have, but we didn't initially have more options, but you could definitely do an external fixator. And a lot of places can do that, at least for temporary fixation. Because you need to have some sort of stability while you kind of take that infection out. And then you're left with about 7 to 8 centimeters of bone defect, if not more. And then I guess the question I would ask, the whole faculty is, and everybody in here is, what would you do in an ideal setting? Like if this would happen in Boston, for example, what would be after the debridement and treating the infection? What would be the next step for that case?
Okay, let's see. We have, I don't know if Dr. Rodriguez is already with us.
Right here. Hi, hello, everyone.
Okay.
Good morning to some, good afternoon to others. That's the beauty of the international sessions. Such a pleasure to join you all today. And I'm so appreciative to Dr. Prada and Dr. Agarwal for inviting me. And I'll start saying, that's an unbelievable outcome, no matter what setting you're in, because the case you presented is probably as challenging as you're going to have, period, in the management of the humerus non-union fracture with bone loss or whatever, and even in Boston, of all places, I would be very, intimidated by having to deal with such a large bone loss, and bone transfer like you did, it turned out beautifully. It was very clever to do it retrograde. It's very challenging in the upper extremity, and thankfully the patient, I understand, had no neurovascular issues, which sometimes happen from the transport itself, right? So what will we do here? Well, the first thing we would do is exactly what you did. A very comprehensive debridement. If we are inheriting this case from a previous situation a few weeks or months old, when there's an ongoing infection, the priority obviously is to manage the soft tissues and the infection. Without soft tissues and with infection ongoing, there's not much you can do. Whether you temporize your limb with an external fixator or even with bracing, thankfully the humerus is a little bit more forgiving than most other extremities for even non-instrumented support, like a brace or a Sarmiento brace or something like that. But without infection resolution and without soft tissues, there's not much you can do. So that's the first phase, and that could take weeks, months. It could fail and you could come back, and then when it comes to dealing with the bone gap, that's a problem. Transport is a great solution. We will probably end up harnessing some transport, a combination of shortening and some masculine technique in different phases. What you did in terms of a transport initially, you converted a large segment loss to a more of a typical looking non-union, and then you dealt with the non-union in a more conventional way with local bone grafting. I think we would have done pretty much the same thing. I'm probably not as successfully as you did, to be honest. Congratulations in that case.
Appreciate it. I think that my next question, discussion, if you allow me, call it, is to kind of any thoughts about fibula grafting or some sort of, and then you mentioned shortening, and then I think that's a question that everybody kind of debates all the time. How much shortening would it be acceptable? Because she and my specific patient, after all this, she did not want anything less than at least what she has right now, because of her situation. So I guess those are my two questions for those.
So I'll address the shortening first. Shortening, obviously, particularly for a young patient or a laborer or has issues both from the functional perspective and also from the cosmetic and personal perception perspective. Functionally, I think you can tolerate a fairly substantial amount of shortening, maybe in the order of 7-8 centimeters if you really have to. I mean, it may result in some decrease in elbow motion or alter the mechanics of your muscle, your force length muscle relationship for your arm, and that would affect you functionally. In a non-dexterous arm, that's a bit more tolerated. But that's probably about it. I think more than that, patients don't appreciate it. Now, granted, if the alternative is an amputation, they might be a bit more willing to consider shortening. In terms of you have a first part of the question that is just to do with me.
About Dr. Rodriguez, Pierre-Marie was asking also about the role of some sort of free vascularized bone graft. He asked specifically for the fibula, but
yes.
there are other options.
So the vascularized bone transport is an excellent option, and we are thankful that we have colleagues that work in our department. We've actually hired our own orthoplastic surgeon, and the field of orthoplastics is a very developing field here in the United States, in which plastic surgeons work very closely with orthopedic surgeons for these kind of flap reconstructions and free bone transfers. So yes, I would, in the role I see for the vascularized fibular graft or other vascularized graft is more for a recalcitrant non-union. I would certainly try to get this healed if possible with one attempt at a masculine or bone grafting with fixation. If it doesn't work, then as long as there's no infection, then you can move on. Then we would consider moving to a fibular vascular graft. And that's a bit more complicated, obviously, because of the resources that procedure will require, and also because it requires a good vasculature, right? And in the case of trauma, that may not be the case.
Thank you, Dr. Rodriguez. So yeah, I think that addressed very well Pierre-Marie's questions about what do we do when we face a critical bone defect that most people will say is between 5-6 centimeters, and shortening. I'm surprised about but we don't have, I guess, a specific number about how much patients tolerate properly. But I think as far as I'm aware, the literature went around 3 to 5 centimeters. Having that said, I think it's also good to bring the point. I don't know what the rest of the faculties, Pierre-Marie, Danielle, Dr. Rodriguez's experience with the masculine technique, because it's a very interesting meta-analysis published in the Journal of Hand Surgery just a couple of months ago, showing that the masculine was not inferior to this kind of workhorse that we have with the advent of bone vascularized free grafts like the free fibula graft. So, which was surprising for most surgeons to come up with this evidence recently showing no significant difference. I don't know what's your experience, Dr. Rodriguez, Dr. Chuto, and Dr. Woolley with the masculine technique.
I mean, I got started. I think Daniel has a really good point as well. I know we've worked a lot in the past about this. I think that masculine is a great option for small defects. I don't think that over, I'm gonna say 5. Well, the literature goes. He says about 5 to 6, sometimes 7. I don't think that I've not personally succeeded in doing anything with masculine over 4. I think that over 4 it's overstretching, and I can eventually, maybe that's my experience, maybe I'm not there yet, but I've found that what Dr. Rodriguez said, which is between a combination of both transport and masculine, because you have a short masculine and you can do a transport, has a better merit. But I do think masculine is a great option for segmental bone defects that are not too much. I don't know if any other faculty have opinions about that, but
yeah. The masculine is a workhorse technique, right? I think it's very useful because it can be done in all kinds of settings, right? You do not need fancy microscopes. You do not need plastic surgeon, microvasculature things. You need to have like, soft tissue viability monitoring afterwards. So it's really a very useful tool that I think most orthopedic surgeons who may not have the support of a sophisticated plastic surgery team to help you rely on. And I use it very frequently. We use it not just on the humerus, but we use it on the tibia, the distal femur, and there's masculine that is reasonable, and there's masculine that's kind of heroic, right? And I think we have all had heroic attempts at masculine over large gaps with more or less success. I think that's really more of a without any other options. You can attempt that. The nice thing about the masculine is, other than burning the source of your bone graft, it's not, you don't burn a major bridge, right? You're burning a smaller bridge. You do have the risk of infection. And of course, obviously, every time you intervene in a traumatized limb, things can go badly. But it's not the end game, right? Once you do a fibular graft, if it fails or it doesn't work out, then you've pretty much run out of options, I would imagine, and you're getting to the point where amputation becomes more of an option that you have to discuss. But we use masculine very often. The masculine also is a term that encompasses many different ways of doing it, right? Some folks do pure masculine, which is putting fresh bone graft over a defect. Some people do an internal cement spacer that maybe has antibiotics, and then limit the masculine to the periphery of that, so that you don't use as much graft. Some people are using meshes and other different combinations of spacers that are supplemented with bone graft in a way that it kind of falls under the masculine flag, but it's not the typical masculine procedure.
Thanks, Dr. Rodriguez. Daniele, what's your experience with induced membrane technique or masculine? And I don't know if Pierre-Marie or Daniele, you guys have available like a microscope to do a vascularized fibular graft at your institutions, and what would be your suggestions and your experience with those techniques for critical bone defects? And there's also a question that any of the faculties feel free to answer about in the chat is coming, and also in the Q&A, about using non-vascularized fibular graft for critical bone defects. So,
okay, Carlos, I do agree with what Dr. Rodriguez says. That is, the masculine is actually a technique that can be used everywhere in all kind of setup, and that's why when we, or at least personally, when I did attend conference and we see the work on masculine, is very attractive because it's quite simple and replicable. But the weak point of the masculine technique, which is not available in all the setup, is to have enough bone graft to have a successful masculine. And so if we're talking of, because we don't have access to RIA, we don't have access, the only bone graft we can get mainly is iliac crest. We can do both iliac crests. So at the end of the bone graft, what you see in that pot is really little, no matter how deep you go and harvest. So if we are talking of large bone defect, I would say it's not possible to have a successful masculine with just little bone graft. At least that's my experience. I was very attracted at the beginning. Most of them were unsuccessful, so I changed my practice. Regarding the avascular fibular graft, I wouldn't talk about it just because we might have a case at the end of the case discussion, so I don't want to ruin the surprise about that topic. So if we can put that topic on hold, we can open this discussion at the end.
Okay. Thanks. So let's come back to the basics then. Before we started with a very complex case because Pierre-Marie had a horrendous case with great results. So I want to congratulate him as well. how do you guys work about typical humeral shaft fracture? Like you receive a humeral shaft fracture, you treat them. How do you treat them? Like there's an art about like the non-operative treatment. Do you give it a go? What are your indications or your absolute indications for surgical right away? Just to start from the basics and build up from there some concepts. So I don't know, Pierre-Marie, how do you approach your patients with humeral shaft fractures? Do you offer them surgery? Why not? And how do you perform the treatment? How do you follow them up? And how do you decide when is a non-union? Which tools are you using in your practice?
Those are really good questions to start off the conversation, because I think that every different places is different, and I think that also the patient population and the patient who you are treating is different. My classic teaching was you don't fix primary diaphyseal humeral shaft non-unions. They heal quite well with a Sarmiento splint or with a coarctation splint or with some sort of fixation, and then you can move to Sarmiento after 2 weeks. That was my initial, training, because you would have good literature that supports non-operative treatment for humeral shaft fractures, and which you still do. So I would say that most of my transverse, non-complicated humeral shaft fractures, I still do non-operative treatment on them because of my setting, because of the limited options that you have, and because of the risk that you would have doing surgery as well, depending on who's doing it. So I guess to answer your question, most of my cases I do non-operative, at least initially. Now, there are some indications that I do use. I go to surgery. If it's a young, active, very active patient that is the working man of the family, most low-income settings you have that, and he needs to get faster healing and faster, then I would opt either for an IM nail or a plate, depending on the options that we have available. And then I kind of move forward with that. If the patient has lots of comorbidities or it's an open fracture in the case I showed, or if it's a really highly committed displaced, there are some indications for initial operative treatment of your shaft fractures. As far as the non-union, I think that I don't wait 6 to 9 months, which is the traditional teaching. I think that I go with the X-ray and I go with the evolution. So if at, let's say 2 months, 2.5 months, 3 months, I'm not seeing any callus, I'm still seeing movement, I'm still seeing early signs of non-union, then at that point, I make a decision that either I wait, if I feel like there's some sort of callus formation, but if I don't, then I go to surgery. I don't wait the whole 6 months to 9 months and then to make a decision. Again, because in my setting, most of those patients are the providers of their families, and they need to get back to work. So that's kind of my go-to in kind of fixing those.
Thank you, Pierre-Marie. What about you, Dr. Rodriguez or Daniela? Maybe let's start with Dr. Rodriguez. What are your indications for going for an immediate operative surgical treatment in patients with humeral shaft fractures? Obviously, obviating like the fact that the open fractures will need debridement and surgery right away. But what are your
So except for the acute urgent case, right, when it has open or vascular injury, I would say never acute. And here's why. I'll tell you what typically happens here in our setting. Some, and granted, humerus fractures is one of those fractures that truly happen at all stages in life. You get young kids who, here in America, the college kids have a few drinks and then start arm wrestling, and I see a fair share of fractures from arm wrestling, believe it or not, in the large college population. And you get those kids that have excellent healing potential, and you get the more geriatric patients or diabetic patients or folks who have other issues that can delay the healing. So there's a whole spectrum. So what happens here is the patient who sustains a humeral shaft fracture is either seen at an outpatient center or a walk-in facility and put in a brace and asked to follow up with the surgeon for surgery, because to the non-orthopedist, emergency room physician sometimes, or primary care, an X-ray of a humerus fracture looks mighty impressive, and often I have to talk down the patients from a demand from surgery to a somewhat more conservative approach. So they come to see me in the clinic, and this is about usually within the 1 week period. And I actually spend quite a bit of time talking to them. And the things I explain are, look, mostly, if you look at the results over recent times and in the literature, most of these fractures actually do well, but the non-unions are actually a bit higher than what the literature, I think, represents. And this may be just my particular impression. I do think that a lot of these fractures fail to heal a bit more often than what we think. And the problem is that they don't fail very obviously often. It's not like you have a flail arm with a very obvious non-union. That's easy. The problem is the fracture that has callus, that has a healing, that has perhaps what I call little spot welding of a large fracture plane, that for all intents and purposes, may look 3 months out like a normal arm, and the patient may be back at work, may be working, but they can't lift anything heavy. They're having pain at night. They're still having symptoms, and then you get a CAT scan, and you still can't tell whether it's healed or not healed on imaging. And then you finally agree to do something, increase the rigidity, and you add a few screws or a plate, and boom, perfect happiness within a couple of months. So those fractures that are non-unions or partial non-unions are often, and I think in the past we have counted those as successful radiographic healings, and it's not the case. So my recipe has been the following: I talk to the patient and offer conservative care. I bring them back at 2 weeks and at 4 weeks. By 4 weeks, you can tell almost by the symptoms of the patient if things are going well. You may not even need an X-ray. You can get an X-ray, obviously, because you're there and to reinforce your thought. But most patients who are exhibiting successful healing have less pain, are able to come off their fracture brace, are able to use their elbow to maybe feed themselves if not lift anything heavy, and they're regaining some degree of functionality and are happy. And at that point, you say, well, you seem to be doing okay. Let's continue conservative care and see how you do. I'll see you now at 6 weeks. And if by that time, by 4 to 6 weeks, if I am not convinced that the patient is progressing positively, if the patient is having pain, if the X-ray is somewhat equivocal, I say this may not be going well. I think at this point, intervening 4 to 6 weeks out is not really a non-union. I think that instrumenting your arm will help you, even though it's a little bit later than acutely, but it's not the same as doing a non-union 6 months later. It's a bit of an easier problem where a primary fixation without bone graft, without any of those non-union additions that we do, tends to do very well. So I make a decision between week 4 and 6, to proceed with surgery or continue conservative care.
Thank you, Dr. Rodriguez. And what about you, Daniele? So what are your tools? How do you decide when it's like a non-union, and which criteria do you use? Do you use any of the radiological criteria as described by Dr. McKee for example, in the article that was part of the prior articles, like a prior readings for the participants, like the Rushu score, or do you use like the micromotion? Or what is your personal preference?
My preferred reference for detecting or deciding if it is a non-union, that's your question?
Yeah, exactly.
I kind of very similar to the opinion of Pierre, what he was saying in the video. So for me, it's just, I kind of abandon all the criteria of time and all these other things. So for me, it's kind of, you don't see any progress between two checkup. So if I don't see any progress radiological and clinically, it can be also 2 months only. So for me, it's going into non-union. So I don't see any progress. Can also be only a very short time, maybe two months. This idea of waiting, I kind of abandon. So there is no progress, it's not going to progress anyway. So something we have to intervene.
I fully agree. So yeah, we what the three of you have said, like basically, there's very interesting finding in that article that Dr. McKee was did a review on this topic, saying that the specificity of like the micromotion reported by Drisman and the group 3-4 years ago at 6 weeks, if there is motion like clinically, it's like a 90% specificity of undergoing a non-union. So that's obviously not always the case, as Dr. Rodriguez said. Many of the cases are not like that, but that's a very like clear criteria that we might be using, like when deciding if at 6 weeks the things are not, the fragments are moving around. It seems pretty clear. And there's also some like radiographic scores that people can look at it and maybe include it in their armamentarium for decision making at 6 weeks as well. The Rouge score reported a couple of years ago. I think it's useful. I find it useful, as Dr. Maki described as well in his JAOS article last year. But they are asking about specific patterns. Like, any of the three of you operate right away for a specific pattern just because it's either a short oblique pattern or like a transfer fracture, there's a lot of gap, or do you just keep an eye on it? And do you have a preference? Because in the chat that question is coming up about like if there is any fracture pattern that leads you to decide surgery right away.
No. So I think I can go ahead. So the two things I would say is, depending on your setting, and if you look at literature, right? So you know, being in Haiti, you have access to North American literature, and there's also European literature. The Germans are actually very, very inclined to do primary fixation of humerus fracture, and they came out a paper in Injury recently about that. And so depending on where your setting is, the arguments are, you know, it looks displaced, it's completely commutative, you need to do a surgery, it doesn't look right, you know, just like the clavicle, right? They heal well without any intervention, most of them. So I would say that there's no, as far as I'm concerned, there's no specific pattern or any literature that would say, well, you know, if this is 5 pieces, it's not going to heal. Like, as long as you're neurologically intact, as long as you're vascularly intact, and that you can have a right alignment, I'm more for non-operative treatment. Now, I do have a conversation with the patient. I think that's also important, because some of them, you know, they will listen to what you're saying and then still say, well, it doesn't look right, I'm gonna, you know, so then they know this is the reality of it. You're gonna heal, most of the cases are gonna heal well, regardless of the fracture pattern. And then, you know, if you get to a non-union at some point, hopefully early on, we catch it up and then we treat it. So that's kind of my go-to on that. I don't know what the other faculty have opinions about that.
I used to think that a plain transverse fracture was somewhat a bit more prognostic of not doing as well as one was more oblique with more fracture plane, right? I'm not so sure anymore. You know, I think what happens with the transverse fracture is during those first 4 to 6 weeks that it takes for the fracture to kind of solidify a little bit, the patient's more unhappy because it's a bit more obviously unstable, right? So there's more complaints, and I think that ties with my psyche of maybe this is not going so well. But if you were to factor away, you know, to try to discern just based on radiography whether a fracture pattern is more or less likely to fail to heal, I'm not so sure anymore. But I would urge you, you know, I've been doing this for almost 30 years now. I still can't tell sometimes, regardless of the scoring, regardless of the micromotion. It's like, really? You get these arms that are big and you're trying to assess motion, unless there's some kind of more quantitative way of doing it. This is still very much a clinical interaction with your patient to kind of decide how things are going, using your clinical data, the exam, to supplement it. There's nothing more predictive than a patient that actually feels pretty good. And if that's reinforced by a positive X-ray and by ability to be examined out of the brace and go do shoulder motion without any pain, that's actually prognostically good. And you know, you won't find papers describing I feel good about the exam and my conversation with the patient as a rational scoring system. But I would encourage you to not dismiss that aspect of your interaction.
Yeah, thank you, Dr. Rodriguez. I think that's very important. And Daniel, I think you were going to say something.
Yeah, just a quick thought. Since Pierre talked about literature, I think one of the fascinating part of orthopedics is also has there is a lot depending on the community and the people you work with. I mean, the type of community you work has a huge impact in the type of orthopedic you practice. So, for example, in my setup, and maybe if there is some of the audience who come from rural area, it's impossible to keep a patient in a brace more than a week. Impossible. Despite you give the talk, you explain, you tell, it's impossible. So I tend to be much, much more surgical rather than conservative. Not by choice, not by literature, but just by no other option, because these people are so strong, they really need to go back to work. I've seen the biggest failure I had is in hardware. They are able to break all kinds of things, plates. So for Humeral, I tend to be much more surgical than conservative, which goes a bit in opposite direction.
Thanks, Daniele. And I fully agree. Like, and everybody will know and read everywhere, like that patient preference can be a very strong like indication. And if they are like the primary person that like brings like basically supports economically their homes, or they cannot tolerate, there's a lot of other soft indications to go for immediate surgical treatment. I fully agree. Okay, let's keep going with the second case, and then we will discuss a little bit more about how we work up these patients in terms of which metabolic, if any, we order, any imaging, and then the role of like dual plating that some people has been asking about, and maybe the role of bone graft or substitutes if they are available. We will talk about that in the next case, after the next case. So Dr. Sarthak, Nepal, would you please share your screen and show us your case?
Sure. Can you hear me, Dr. Carlos?
Perfectly.
Yeah, okay. Can you see my slides?
Yes, but I don't see it in full screen mode yet. Yeah, that's perfect.
Okay. Okay, hello everyone. My name is Dr. Sarthak Nepal. I'm an orthopedic surgeon at Nepal Orthopedic Hospital. It is situated in the capital city of Nepal, that is Kathmandu. First of all, I would like to thank the Harvard Global Orthopedics Collaborative and SONA Global for giving me an opportunity to present my case from my hospital. So the topic of the presentation is the non-union of distal humerus fracture with broken implant in. So this is a case of 28 years old male who's a laborer by profession, who is a non-alcoholic, a non-smoker. He's a non-obese patient. He does not have any other underlying comorbidities. He had sustained road traffic injuries some 9 months ago when his bike hit a small van, and he sustained injury around his right elbow area, for which he went to the local regional hospital, and he was diagnosed as a case of closed fracture distal humerus, where he underwent open reduction internal fixation with dual plating. So he says he had some issues after the first surgery he underwent. There was a problem with the wound, and there was a bit of a serious discharge from the wound, probably maybe due to a surgical site infection. We don't really know, for which the hospital stay became quite longer, for about 17 days, and his suture was taken out only on the 28th day. And he was kept on immobilization with slab for about a month time. So coming on to the timeline of events after his slab was removed, his primary surgeon advised the patient to have the physiotherapy immediately after the slab was taken out, but due to his pain, he could only start the physiotherapy session, that is the range of motion of his shoulder, elbow, wrist, hand grip exercises, only on the 45th day post-surgery. The most important finding is on the 4th month of the post-operative period. While performing his physiotherapy, he noticed a sudden pain over his elbow, and there he noticed a cracking sound from his elbow, and the patient suspects to have a breakage of the implant at that time, but he did not seek any medical attention and did not go to the primary surgeon or the hospital where he was operated. He only went to the hospital at about 6 months status post-surgery, and he says there was an X-ray done, and we don't really know what advice was given by the primary or treating surgeon at that time. So after that, 3 months had passed, and on the 9 months post surgery, he visited our outpatient department at Nepal Orthopedic Hospital. In our hospital, we clinically examined the patient. There was a posterior longitudinal scar. There was no any sinus tract or any sign of an infection at that time. There was a tenderness present over the distal humerus area. The swelling was present over there, and when we evaluated the distal neurovascular status, it was intact. On examining his range of motion, there was a limited range of motion. The flexion was only about 100 degrees, and extension was limited to about 45 degrees. So we ordered investigation for the patient, both the imaging and the laboratory workup at our center. So this is the preoperative imaging X-rays that was done. This is the AP and lateral view of the right humerus area, showing the fracture at the distal humerus area. We can see the bit of a diastasis at the fracture site. We cannot really see much of a callus formation at that time at the X-rays, and we also can see the broken implant, the plate, and both the screws. And on the lateral X-ray, we also can see the bit of a malalignment of the fracture here. So coming on to the X-ray and clinical finding, due to the persistent pain, progressive deformity, and no radiographic evidence of healing, as well as the movement of implants, we give a presumptive diagnosis of non-union distal humerus for the patient. So we ordered for a laboratory workup where we did a complete blood count, ESR, CRP, and other tests like vitamin D, PTA, and to see the thyroid function test and other related tests to rule out any other metabolic disorders as well. So the provisional diagnosis we kept for the patient is aseptic non-union right distal humerus with a broken implant or the failed implant instead. So for the surgery, we made a goal for the patient. The goal of the surgery we kept was to achieve a good bony contact, a good compression at the fracture site, proper alignment, and to have a very stable fixation for the patient, and also to enhance the biology with the bone graft. For this, we did a posterior approach in the patient. We split the triceps and isolated the radial nerve. We looked around the hardware to see if there is any sign of infection, like any fluid collection or any of the reaction around the plates, but we could see neither. So we confirmed that it was not infective non-union. Then we removed the hardware. We fixed the fracture with a 10-hole dynamic compression plating. And harvested the bone graft. Before harvesting the bone graft, we also decorticated the non-union site. So this is the immediate post-operative X-rays. We can see the AP and lateral views. In case of the AP and lateral view, where we can see the 10-hole dynamic compression plating. We can see the anatomic reduction of the fractured fragments. We also can see a good amount of compression. We cannot really see malalignment of the fracture site in both the AP and the lateral X-rays. Post-surgery, we evaluated the patient for his distal neurovascular status. For all the median nerve, radial nerve, PI and AN, all were intact, and there was no issue with the wound post-surgery. I could not find his recent post-op X-rays, so I could only manage to find a 3-month post-operative X-rays. This is the AP and lateral view of the operation that we did in the patient. And here we can see good amount of callus formation. Still, there is good alignment in the case, and quite a bit of callus formation and compression is seen in the fracture site. This is a 6-month post surgery. The callus has increased and there's a good amount of callus formation. Although we can see a little bit of a fracture line, but the fracture has healed. And we also examined the patient clinically. He could do a range of motion on the flexion, which is about 110 degrees, which is better than the preoperative clinical examination that we did. And he could do the extension for about 30 degrees. There was no problem with the scar. The scar had healed and there was a good functional outcome. I could not manage to get deep imaging of the patient, however. So I think the most important learning objective from this case could be the proper planning of the surgery, and the proper approach should be used. It is very important to restore the alignment, the compression, to achieve the stable fixation in the patient and to have the early mobilization in the case. The second point is to rule out infection. It would be a disaster if we operated in him without ruling out the infection. If there would have been an infection, we could have done it in a staged procedure, as we already discussed in previous case as well. And the most important objective here is not doing aggressive physiotherapy, which might have led to the breakage of the implant in this case. That is all for the case. Thank you so much.
Thank you, Dr. Nepal. It's yeah, interesting case and great result at the end. It will bring us some points to discuss definitely regarding like how to work up a patient with a prior surgery that underwent non-union. I would like to hear that from the faculties. Let's start with that point, and then we will go about how to route infection. And because there was an history about discharge in the first month reported by the patient, so there's a significant concern anytime we have an operated humeral shaft fracture that undergo non-union. So for the faculties, first question. So what is the workup you do for a patient that has a humeral shaft non-union that underwent surgery, and how does that differ from a patient that has a regularly non-operatively treated humeral shaft non-union that undergo humeral shaft treated non-operatively that undergo a non-union? Is there any different that in your workup approach?
That's that's a pretty good question. In my mind, and maybe I have not a lot of experience over the past couple of years, but in my mind, if it had either surgery or some sort of fixation internally prior to coming to me, I consider it infected until proven otherwise. That's at least in my thought process. So I kind of do the basic labs that were done, and that's a really great case. I really like the way you did the compression, and I do basic labs. But the way I do it, maybe I'll do it a little bit more aggressively, is that I do serial labs. I don't rely on one result. I make sure that I have at least 2 to 3 results, even though it's a financial burden for the patients. But if I'm gonna go into this revision surgery, I want to make sure that at least I have some documentation that says, well, it's okay, it's fine. The second thing I do is once I get to the actual surgery, I kind of do a similar technique that what Dr. Nepal did, but I do swabs, and I do take cultures. So even though I consider it an aseptic non-union and I fix it, I still do I still work up an infection. And if I have a recent infection, then I address it at that time. But if it looks not infected, it's probably not. But I'm maybe a little bit over aggressive into that. I don't know what the other faculty thinks about that.
So,
Sarthak, do you mind stop sharing the screen? So
Yeah, sure.
Thank you.
So Dr. Nepal did the right surgery for the right problem. But I want to rewind a little bit because we're talking about non-unions. So and go back to when this first happened, right? I mean, and we don't know the details of the situation. We don't know, you know, but I assume this was not an open fracture. Was there a reason to do surgery the first time?
Yeah, it was a closed fracture as far as the history
So
suggests.
it was a closed fracture. It also wasn't a distal humerus fracture in the intraarticular sense, right?
Yeah, yeah.
So it was
was
really
not an intraarticular. Yeah,
it was a distal third humeral shaft fracture.
Distal third. Yeah.
So we could have, based on our conversation from before, not done anything surgical. and see how this could have been managed non-operatively. And granted, this was probably a working man who had to get back to work. And what Dr. Shuto pointed out, sometimes you have to do preparation for the patient. Don't treat the X-ray, treat the patient and the patient's environment and their needs, right? And maybe that was the reason why a surgery was done. But I will point out that it was done with dual plating, right? And when you do dual plating on a shaft fracture, you don't have to. If you do a good reduction and compression, you can achieve that with a single plate. Dual plating in a shaft fracture strips a bit more of the periosteum and kind of diminishes the vascularity of the site, potentially even contributing iatrogenically to what happened, right? I would argue that if you were going to do surgery, the previous surgeon should have done what you did, Dr. Nepal. You know, posterior approach plating or anterolateral approach, and a single plating compression with good technique may have been a more sufficient fracture, and perhaps would have avoided this. Anyway, that's just a comment in terms of what could have an alternative pathway that could have happened from the start. In terms of working up the non-union, yes, you know, so if I am concerned because of the story is very concerning for a post-operative infection, discharge. I think you mentioned 17 days in the hospital. You know, no one stays. I don't think that even in Nepal people would stay 17 days in the hospital there's a suspected problem, right? And I would imagine this patient probably did have, if anything, a soft tissue infection, and it was just fortunate that it didn't turn into a deep bone infection. So it was clearly a concern. I think that the appropriate set of labs, cultures, you know, for what it's worth, the inflammatory markers. But many times, in the absence of a soft tissue, of a very obvious soft tissue drainage or sinus, you can't tell. You can't tell until you're actually in the surgical bed, right? At which point you do your deep tissue cultures, and then make a judgment at the time of the surgery as to whether you are concerned if this is infection. If there's pus, obviously, but sometimes there's not even pus and it could still be infected. So I always face these non-unions that I assume they could be infected. I always culture them, right? And if it appears overall healthy in the sense that it's not grossly purulent, I fix them. I fix them even if they turn out to be infected later on. I do the appropriate mechanical reconstruction, and then I pending the cultures, I will then overlap a 4 to 6 weeks course of antibiotics to address the infection. Now, if it's relatively purulent, if there's necrotic bone, I do the appropriate debridement, and I may choose an alternative way of stabilizing the fracture. You know.
Thank you, Dr. Rodriguez. What about you, Daniele? What will be your workup study for these cases? How do you work them up? Do you do something different when patients underwent surgery and they fail, or you do the same with a non-operatively managed non-union?
Okay, yeah, my answer is very fast. It's very quick. It's just I don't have workup, so I don't rely on them. So unfortunately, the only thing I have is a full hemogram, and sometimes we get stock out of reagents, so we don't even have a full hemogram. So it's actually not part of my practice for this case using the workup. What has become part of my practice, it is the debridement. So what I call the oncological debridement, either if it's an open fracture at the beginning or if it is a non-union that you have to revise, the biology and the debridement for me becomes of paramount amount because I cannot use the workup. So wherever I'm involved with the debridement, that debridement has to be thorough. I mean, it has to be a real oncological debridement where everything that looks not good or septic or that has to come out. The second thing is the respect of the blood supply, because when we are talking about this kind of surgery, okay, we jumped straight to the complex case, but as you said also, we have to go back to the basic of this non-union. When we talk about this case, there is always a lot of biology involved, and most of the time this biology is also damaged, because most of our non-union comes from failure of plating, like this case I showed. So even the basic dissection, when you go in to treat a non-union, is not a normal one, because all the soft tissue are full of scar, and the basic things like isolate the radial nerve is not so basic, because now everything becomes. So I want to point it out that those are, for me, are always challenging surgery. They're not easy. There is always a lot of bleeding involved. The first things I check the day after is the radial nerve is intact, because sometimes you're not even sure what happened there. And that radial nerve, as one senior surgeon told me once time, you just look at him and he just goes impassive just by looking at the radial nerve. So it's a very tricky nerve. Anatomy is distorted. So they are complex cases, I think. So those are cases you don't want to put in the afternoon, maybe after a long list. So that's another, I think, point which is important. So now in all this, that's what I'm saying, the radical debridement becomes important. So everything that doesn't look good, you think is septic, goes away. And the revitalization of the blood supplies is very important, because that's what's going to, if there is some remaining of the infection, it is our blood supply that is going to kill that infection. So now also the decision of which implant and how you put the plate, and also how many screws you're going to put. Now, those are things that I think is also interesting to discuss, because even myself, I don't have a clear idea. I was watching also the case by Dr. Nepal. We have a lot of study where it's been proven that mechanically, when you put 3 screws and 3 up and 3 down, that's already the maximum stability you get. So you don't need actually to go to 4 and 5 screws in the plate, because you are not adding any more stability to the construct. And on the other hand, you are kind of jeopardizing the blood supply on a bone which is already struggling to heal. So my question might be, we still see a lot of cases with this plate have maybe 4 or 5 screws. So sometimes I ask why we put that number of screws. I don't know. I myself, I don't have an answer. I just, it's just like food for thoughts I want to share with you.
Yeah, maybe because we all been there where those 3 screws are not that good of a screw, right? Those 3 screw up and down, 6 cortices. Yeah. So yeah, thanks for sharing those thoughts. They're very important. And when you don't have I don't know if the rest will agree with me, but if we don't have the proper workup of these patients, I think we should assume if they have a non-union and they have been operated before, we should at least be suspicious of an infection, and then do like a proper like irrigation and debridement, take everything that looks dead until we have bleeding bone, and try to think that this is like a septic or possibly septic non-union when there's a prior surgery. I mean, if obviously it's a big callus, like a mechanical failure, like an hypertrophic non-union, we can maybe think about in that different. But I think it's always important to keep in mind, even if we don't have the resources to work out these patients, if there is a prior surgery and a non-union, to keep in mind the fact that there might be an infection. You were going to say something, Sarthak?
Do you think longer pleats are better to, in the case of revision surgeries, longer plate would be better? Because in the previous case, scenario, they use a dual pleating. So that is why I was very reluctant to use a very shorter pleat. So I used a longer pleat. So maybe any of our other faculties could highlight on it.
I think the construct you used was appropriate. I usually do, when I'm repairing a distal third shaft, I use some kind of posterolateral plating. And here I'm fortunate that I have a whole bunch of options to different shapes and thicknesses of posterolateral plates. But you can take a plate and potentially contour it a little bit, even a simple plate, contour it for a posterolateral fit. and that usually suffices, and you use principles of compression along the fracture, and that works. I don't see, I haven't had to use dual plating for any shaft fracture, particularly when it's a first operation. I think it may be detrimental sometimes. I mean, there are those patients who are severely osteoporotic, so I may occasionally use more than 3 screws on each side when I worry that the screws are just not very good. But the only dual plating I do in the distal humerus is for the intra-articular distal humerus fracture when you need that bicolumnar support.
Thank you, Dr. Rodriguez, because you introduced the next question. I wanted you to ask all of you, what is your indication for dual plating, if any? So you already mentioned your preference, Dr. Rodriguez. I don't know if you want to add anything to that. And I don't know if Pierre-Marie or Daniele, would you use dual plating? And if so, when?
Well, Dr. Rodriguez, you want to finish your thought? Or?
So I'm thinking back as we speak, in the shaft of a humerus, I don't think I've ever dual plated. I've gone and made choices to go from a large frag plate when I'm concerned, but haven't had to use a dual plate construct. I'm thinking, yeah, no.
Yeah, so one of the first cases I showed on the video was that I actually did a dual plate. And that was a specific reason for that. It's because I didn't have the implants long enough to get it. So I think that's the only reason why I would do a dual plating, is if I'm in a limited setting where I feel like my construct is not going to be as strong with, although it should be, if it's a non-union, then maybe I'll do a dual plating because I don't have the right implant or the proper implant to do it. One other thought process is using a large frag, which I've done. So instead of going to a 3-5, I've done a long 4-5 screw, like really more rigid. I wouldn't want to do that initially. If you don't have any other choice, you could, because then you're burning bridges eventually, if you have to revise this. But I've not done, I've rarely done a dual plating unless I have limitations in implant access in my setting. That's pretty much their answer for it.
What about you, Daniele?
Yeah, me neither. Never use dual plating, never. Consider that our trauma population is quite young. So basically they have an extraordinary bone healing capacity. So I've never encountered a situation where I needed to dual plate in a humeral shaft.
Okay, I will disagree a little bit, and then not disagree. I would say that obviously it's very unusual to need a dual plating, but I have done it twice actually. One is like the very old population where I feel like today, most of the time, we could rely on a locking construct if available when there's very osteopenic bone. But this was a lady with a non-union, priorly operated, 78 or so, and we basically she broke the prior implant, so we used a dual plating in her. It could have been maybe just a longer plate with more locking screws sufficient, but I think just maybe for the participants to keep in mind, if you have a severe osteopenia, maybe it's a potential indication for a dual plating. That might be a very unusual scenario, but I think it's something to keep in mind. And at least I think it could be considered as well that one time I used 2, 3, 5 anatomical plates for a distal third humeral shaft when I feel that the distal purchase was not enough with one plate. Sometimes it's not like a distal humerus fracture, but it's a distal third humeral shaft fracture. And sometimes, depending on the pattern of the fracture, you feel that your distal purchase is not good enough, because you then start to get into the metaphyseal bone, and then you're not confident on the construct. And I think in those cases, some people might consider as well doing a dual plating through a paratricipital approach. So yeah, I don't think that that's right, but those are potential, I think, scenarios where it could be considered. I want to ask now a different question that is apart from Dr. Nepal's kind of takeaways. How do you rehab this patient? He was concerned about that. He was saying maybe 45 days is too soon. What's the experience of you when you operate them? How soon do you allow them to move? Dr. Rodriguez, Pierre Marie, and Daniele, what are your thoughts on that?
I'll go first because that's an easy one. So if I fixed it and I have a good construct, there's no bracing, there's no cast, it's a sling for the first few days, and then passive range of motion and active assisted range of motion as tolerated. And I tell them here in America, I tell them don't lift anything heavier than a large Dunkin' Donuts cup of coffee, which for the rest of the world is probably the size of 2 soda cans. And I keep him at that. I keep him at that for like the first 8 weeks, and then I tell him do whatever you want.
Love it. It's a very practical way to explain them to the patients, Dr. Rodriguez. That's great.
I think a liter bottle of wine might be a little bit too much, but so that's probably okay.
What about you, Pierre Marie?
Yeah, I do the same. I use most of these patients don't go into a non-union. They auto protect themselves anyways. At least in my experience, they don't try to, you tell them not to lift anything heavy. I like the technique of Dr. Rodriguez. I'm going to use it. I'll use a soda can for that one. That's actually good. But yeah, it's I let them, if I'm confident of my fixation, and I know that there's a really good stability in it, then I just let them kind of do range of motion as tolerated, and then have a physical therapist if available. Or they can do it themselves up to 6 to 8 weeks. But I don't have any really large restrictions because they're not gonna restrict themselves anyway. They're gonna auto protect for a while, and then once they get confident, they're not gonna care what you say. So that's pretty much what I say.
Agreed.
Daniele, do you do the same? Something different?
From my side, no restriction at all. And again, kind of my work plan is a bit on the reverse side. So my community is very strong, as I said, and no matter I give indication, they are not going to follow. I've been here now for 8 years. I know my community. But on the other hand, knowing it changed my practice. So when I treat this kind of fracture, I know there has to be a good fixation. I know it has to be stable. And I think that's also made me a good surgeon over the years. So I cannot accept this kind of things is good enough, or asking the colleague, do you think it's good enough? No, I cannot have that luxury because I know I cannot do those things of like back slab or for some weeks because they are not going to follow. So basically, I try to do the best fixation I can, get it really stable, and then go with no restriction.
Perfect. Okay, so I think we have a couple of minutes to go quickly through one more case. Do you want to show yours, Daniele, or do you want me to show one of the ones I have?
As you are the moderator, if you want to talk about that pending question, I can go. Or
yeah, let's do that. Let's do that. Sounds like a good plan.
Okay. So I'm going to go very fast because I think the important part we want to reach to what the audience was asking, if you agree.
Yeah.
So we're kind of closing as we started. So like quite similar to the case of Pierre. So he was actually 16 years old with a gunshot injury. These are the soft tissue entry exit wound, so high velocity bullet. I think here there is also some good discussion, but not for today, about how you treat gunshot wound injury, how you do the debridement. Some people even say the gunshot are a clean wound. Some people tell you not to close immediately. So there is still a lot of controversial on gunshot wound, how you treat it, but we'll keep that for the next time. Anyway, I did a debridement. We have talked about that. As we said also, he had a radial palsy present. It's Some people do explore, some other people also said, literature basically said in gunshot wound, also you wait and see. That's also what I did. So I took care of the debridement despite the radial palsy, then wait and see. In this case, I actually closed directly the soft tissue. As I said, we're going back to the kind of thoughts I share with you. For me, debridement are very aggressive. It's a tool of fighting infection. So anyway, this was the bone gap. So what I did at the moment, going back to the cultural part, we have this tradition in Samburu where they have to go through a phase that is called a circumcision. So circumcision is something very important for the community. So no matter what, these people go for these events because it's when they become from, let's say, young people to warrior, and it happens every 4 to 5 years. So these people go. So I know that when the time of the year comes, and it comes every 3, 4, if I have an X fix in an open fracture, I have to close because they disappear from the hospital. They have to go to the ritual. So in this case, I have to do something to remove the X fix because he was about to go. So that's now how the plan came in. I put a bone cement, and then I put, this is a sign nail that we mainly use for pediatric for the humeral. So I used it for the femur, sorry, I used for the humerus just to stabilize. I pushed it really down to create also some stability. I was not able to get a proximal interlocking because it was still in the fracture site. So anyway, this was the case at 6 months. So when he actually came back, you see also the dress has changed. Now he has become a warrior. So he went through the circumcision, he's back like a warrior. So he was doing okay. This was November 2019. Now he went, and then he came back after 3 years. So this is January 2022. Would be interesting to get from the audience a bit of opinion, what people would do at this stage. The guy is taking care of his cow, he's pulling, the hands is stable. You don't hear any crepitus. So, so one of the questions can be, what do? You intervene or you wait? Do I have time to ask you guys, or shall I go straight to the point?
You can ask the rest of what would be do.
It's hard to tell from the X-ray because it's becoming diffuse and integrated. Do you still have a cement spacer in there?
Yeah. So there was the second operation. It was definite. So we're talking 3 years after that operation with the bone cement and the nail. You see, and also that
there's no infection. There's no sinus tract. There's nothing concerning like that.
Sorry, Rodriguez.
There's no obvious infection. There's no sinus drainage.
No sign of infection after 3 years. No sinus. No soft tissue are bad because, as we said, we are talking of severe soft tissue injury. But the patient is still even pulling the cow with his hands, and I have no problem.
Yeah. So the young man is performing his daily activities without any concern.
Yeah.
Let him be. Don't solve a problem you don't have.
Okay. And actually, that's what I did. So thank you, Rodriguez, because also I did the same. I let it be. I say, now we reach August 2022, which is somehow different. Has changed the situation. So now the bone cement is start to crack a bit. You can hear it. The nail starting to protruding. The distal part is protruding into the joint, and is not able to do the daily activity. So he says, when I'm pulling, I feel movement on my arms. So now the clinical part has changed. So now that's where we reach to the question of some of the audience. So do you do a avascular fibular graft? And that's what I did. So we don't have the possibility. We don't have a microsurgery, so we don't have the possibility to do the vascularized fiber graft that I think would be a much better option. So in this case was an avascularized fiber graft and a big plate, which the criteria which actually we touch base only on the pre-video, the course by Pierre, are the same, because also when you do this one, the same principle are there. It's get a very good compression, which seems to be the key point of all the non-union. Okay, so also when you do this, it is the same. Also, when you do the fibular graft, is to do this compression, which I believe it's not easy to actually get a good compression on humerus. I don't know your experience, but myself, I found it difficult. Also, not only in this case, but also in a normal non-union, you create, you clean, but getting that very good compression, I found it a challenging orthopedic skill. I think you have to be good. So same principle. The radial nerve was difficult to find, lots of scar tissue. Again, he goes into radial palsy, second time. So anyway, just to close up, so this was November 22. Still a bit of radial palsy. The fibular graft seems to be getting integrated. For sure at the proximal side, I'm not so sure in the distal side. So this was actually the follow-up April 2023. Everything seems to be stable clinically. He's performing what he's doing. I don't see any radiographic changes of movement of the plate. The proximal part seems to be well osteointegrated. Again, I'm not sure 100% in the distal part. And this was the clinical part. So the radial nerve likely has come again, has come back to life. So this what we see on the literature of wait and see, the radial nerve is just like a crazy nerve. Sometimes it's really disappointed, but sometimes you're just patient. So in this case, he revived 2 times and he came back. So this is, I hope you answer a bit the question about the avascular fibular graft. I think it's an option, is another option compared to what Pierre shared with us. I think, I believe so far, I don't consider this case totally closed for the distal part. I'm still following this kid, which is now is not a kid anymore, by the way, because now it's already 4 years down the line. Same principle as we have talked so far. So compression, proper plate, respect of the biology. Biology has to be your friend to treat non-union. You cannot fight biology. I mean, more than ever, they have to be on your side. You have to use it as a tool to treat non-union. And it's an option. It's an option, I think. And it's kind of an extreme option, but it's there. So I don't know from the audience, the people were asking if they want to ask any question about it, or if I've answered the question.
I have a question. So one thing you didn't mention, but I assumed is the case. This is his own fibula. This is autograft. You took his own fibula and used it for this, correct?
Yes. Sorry, maybe I gave it for granted, but
I think that makes a big difference, because here, if I use a vascular graft, I usually mean a piece of dead bone from the bone bank. And yeah, we use here in America, people use these struts that you get from the bag to fill defects and porodic bone and so forth, and those are notoriously for just not doing anything.
Yeah. Actually, thank you for pointing out, because for me it's natural. We don't have a bone bank, so whatever bone put in the body comes from the same body. But I know different setups is different. So thank you, Rodriguez, for actually pointing out.
One of your pictures, I saw a bandage on the kid's leg, and I figured, it's his own fibula, and then and that I think personally makes a big difference, because you're dealing with a not an allographic material, but his natural bone. So it's, even though it's not a vascularized bone, it's a step better than allographic bone. And I think in this situation, this is an excellent solution.
I fully agree with Dr. Rodriguez, Daniel. I think it's important to have, we don't have this evidence. Most of the evidence is like being not so great, and why it's not a great option is because it comes from allograft, but we don't know how well autograft of fibula perform, because many of the evidence comes from places where they do have micro and they go immediately for a free fibular graft, like vascularized. But I think it's very interesting. It's a great result so far. I do agree that it's not close yet. It seems that the distal part is not completely healed, but hopefully it heals. But it's an amazing outcome, and yeah, greatly done. Somebody was going to say something. I don't know if it was Pierre.
Yeah, I just want to kind of point out, this is a great case. I'm always amazed how Daniel, for the past couple of years, we both share a really complex cases in the 2 different parts of the world. And I think I congratulate you from this result. It's just a tremendously great result. I think that one thing that is really important that you mentioned initially, and people maybe we didn't catch it on, he's young, he has no comorbidities, and he's a warrior from what I understand. So I think that patient population is very important. You know, if you're deciding to do a complex revision or a non-union case, whichever setting you are, look at who you are dealing with, right? And I think that that's also important because his outcome is defined by his biology, as people mentioned, and we need to kind of look at that as well, right? So, but that congratulations on your, and that's a really great case, and hopefully he'll never come back, but we'll see.
Daniele, would you mind stopping sharing your screen for a second?
Yes.
And then we will try to answer a couple of questions that came up in the chat and the Q&A. So what is your preferred play? They are asking 3-5 or 4-5. I think this is an easy and quick one, if all the systems are available.
3-5. 3-5. I've done a combo of both once, but like I said, 4-5 is if you don't have the limit, if you don't have the implants, but I usually go to 3-5. That's my go-to. I don't know.
I usually use 3-5 systems, but even in the 3-5 systems, depending which manufacturer, there's a bit of a spectrum, right? So you have the 3-5 non-locking and the 3-5 lockings that are a little bit thicker. So you can get an incremental rigidity even though they're all 3-5 systems. You can also, I wouldn't dismiss the single file large frag plate if you need to use it, because it's usually for a humerus, it tends to fit very well. Most manufacturers will have in the large frag sets, what I mean by single file, the plate where the holes are in line, not staggered. Occasionally I find myself using that one as well.
I would say that, I don't know, Daniel, what about you? I would tend to prefer a 4-5 for a humerus shaft.
Myself, for simple case, I do also use 3-5. When I have to deal with complex case, I also like better the 4-5. Like in this last case was a 4-5.
Okay, then there's another question about like bone grafting. Do you bone graft always when you deal with or never? What's your conduct when you're facing a humeral shaft non-union? I know it will depend possibly if there is any hypertrophic or not, but can you briefly guide me, the three of you, on what do you do?
Well, I'll go first. As a hypertrophic non-union, I think I showed the second case in the video. It is by definition, it's a bone graft itself, right? So you take down that callus, you get your compression, and I usually use that hypertrophic bone graft substance to compensate. Looking at the case that I showed, and I usually bone graft. I think that whether you're doing a bone transport or some side of whatever your masculine is going to bone graft anyway, right? So if you're doing a bone transport and you get to the docking side, I'm one of those young surgeons that says, well, I just bone graft it and compress it. So I usually bone graft. As long as it's a non-union, I go for bone grafting for sure. But that's my go-to.
Here, I'm sorry, I missed that part. Also in a hypertrophic, or you're talking about?
No, so if you have a hypertrophic non-union, like a case I showed in the video, in the video that was sent before, I take down that callus, right? I take down all that callus around the non-union side because it's hypertrophic. And you say hypertrophic means stability. Absolutely does. So if you have a hypertrophic non-union, you have maximum stability, then you should heal quite well because it's a stability issue. I personally just use that bone graft that I take down into the docking site as well. Even though I know that stability is going to treat it, I'm I guess overcautious. That's my thought.
Perfect. Thank you. Dr. Rodriguez or Dr. Chuto, do you have any thoughts on that?
That's such a hard question because there's no right answer, and the more years that go by, the more confused I am. So I'll be very honest. My first priority with a non-union is to provide stability. So if I can provide stability without bone grafting, great. Occasionally, I will be concerned that perhaps the quality of the bone or the biology or a very transverse type of fracture with dubious or a small defect justifies some bone grafting. And what I'll do is I'll harvest some bone graft to buttress it along the side of a suspiciously, concerning non-union in the to improve things. I'm not sure that does anything, to be honest. I think the stability is the primary criteria, and then obviously when there's a defect, you would graft. But by grafting around a fracture that you've been able to reconstruct with good compression may not be necessary.
Just one more point to ask the faculty, and I've talked about the Judet decortication, and I use it quite often, the fishtailing. What are your thoughts on that? I know it's a very old technique. I use it personally because I'm a big fan of Judet. But what are your thoughts on kind of doing that parastral decortication to kind of stimulate more biological response in that setting, besides stability?
I don't do it that often. If I have good, if I'm able to debride my non-union, right, and I'm able to have a good cortical apposition over most of the circumference of the bone, I may just bone graft. I may take a burr and kind of burr a little bit of the cortex. That may be an equivalent to the Judet decortication. It serves the same point, right? It serves a point of like, reinitializing a little bit of the bleeding and vascularity at the most heavily corticated part of the non-union. And I will add the bone graft at that point. So maybe that's I do that occasionally, but it may be the same effect as the Judet decortication.
Okay, guys. So we will have to start closing the session. Thanks to everyone who has joined today. I will take the liberty to do a small summary. Please tell me if you disagree with anything that I say. Basically, I think some things that the audience might try to keep for their, like, as a key takeaways at home are: one is like humeral shaft fractures are mainly treated non-op. There's certain conditions and obviously settings, as where Danielle and Pierre, sometimes if you work in a place where when you're dealing with someone that won't be like following any like immobilization methods, or they need to provide at their homes, things obviously change considering basically the scenario where you're working. But at least academically, humeral shaft fractures can be treated non-operatively most of the time. That's an art. It's not easy to put a use lab. It's not easy. Patients, there's a lot of crossover. Patients that ask to be put out of those Sarmiento braces, and it's not easy, but it's one out of 5 or 1 out of 4 end up still not healing, but you still have 3 or 4 out of 5 that heal, like with a non-op treatment. So it should be at least discussed with the patient and at the discussion be given. Immediate surgical treatment, obviously there's many indications like open fractures, polytrauma, concomitant upper extremity fractures at the same time, and some more controversial could be like it is supposed to be the proximal third shaft fractures more difficult to manage non-operatively because it's more difficult to put the brace and the use lab there. And some people is concerned about like certain pattern of fractures like transverse or short oblique, but those are just something that is basically controversial and not clear indications. Also keep in mind that we need to assess clinically the patients. We didn't talk much about workup, but I think even if we don't have the tools to work up these patients, if there's a prior surgery or if it's an an atrophic non-union, always be concerned about infection. If you do have the ability, maybe consider providing, if you're doing a revision surgery, consider giving calcium and vitamin D to the patients beforehand to try to enhance the chance of healing in your revision surgery. And the use of bone graft, I think, is appealing. Every time we need to augment the biology. So there's either a prior surgery or an atrophic non-union. And when we have bone defects or critical bone defects, we have many tools available depending on the scenario where we work at. we can either do bone transport, shortening. We have vascular bone graft, that is kind of the main workhorse, and the induced membrane technique like the masculinate. But if we don't have those tools, also like a non-vascularized fibula, an autograft, as Daniel showed, could be a good solution in certain scenarios as well. Anything that either Pierre, Dr. Rodriguez, or Daniel would like to add to this?
No, this is a great summary. Thank you so much.
Yeah, absolutely.
Okay.
I think a good closing, I would like to add what Danielle pointed out. You know, treat your patient and treat the role they serve in your community. Don't get so fixated on the X-ray. Ultimately, never forget you are treating your patient, not an X-ray. And sometimes decision-making has to adapt to the needs of your patient. And that's why that engagement and conversation is very important.
Well, thank you all. For the participants, please, that attended the leave session, try to complete the course evaluation, then you will receive the certificate of participation. And we invite you all for our next session that will be on December the 2nd on elbow instability. That's at least personally, my favorite joint. So for all elbow lovers, please tune in on December the 2nd. Thank you, Pierre-Marie. Thank you, Dr. Nepal. Thank you, Dr. Ken Rodriguez, Dr. Daniele, for your great cases and your great insights. And looking forward to see you on December the 2nd.
Carlos, thank you for a great moderation.
Thank you very much.
Thank you all,
Thank you.
faculty. Thank you.